Okay. Yeah. Yeah, Doctor, you can start.
So this is a 9-year-old boy who came with so no previous complaints, no previous so birth was normal, no problems at birth, normal milestones, and suddenly for a week here, acute onset right arm weakness. But along with the weakness, he was having excess movements of his right arm. So when I examined him, and there are some videos in the next slide. So when he walks, the first.
Which one do you want me to play?
Yeah.
The middle one?
Yeah. No. The first on the left.
Okay.
Yeah, this one. So when he walks, if you see the right side arm swing is less. And he's also sort of right leg, he's trying to, in spite of that, when I asked him to pick up the toy, he was picking with his right hand. So when he walks, he's not able to swing his right arm that well, but he's still able to use it well. And when I made him I want to check the pronator drift, he's able to lift his arm well. But as he keeps it on for some time, there is some right arm movements, while the left arm distally, they aren't. So, the choreothetoid form of movements. So right side weakness, acute onset, with right side abnormal movements, so more choreiform. So I think it's the same videos. Last one, again, even though it looks, the history was weakness on the right side. When he walks, it looks like as if he's got weakness in the right arm, but he's able to use it well. There was no pronator drift. And if you see now in this, so in the right hand, he sort of has choreothetoid movement. When he walks, he sort of has a limp on the right side. So my differential was it a stroke he has had? But I was confused that in spite of this weakness, he was using his right arm well. There was no pronator drift, and I could not explain the movement disorder which he has in the right arm. So I thought maybe the stroke is in the basal ganglia. But again, it's really odd in the basal ganglia still to acutely have a movement disorder with the weakness. Maybe it comes later, but not acutely. So we did his imaging. So can you show the imaging now?
Yeah. So the imaging on top, we have the panels concentrating on the deep gray nuclei. And at what time frame was this done from the symptoms, Dr.
5 days.
5 days, okay. So we can appreciate a cystic or cavitatory change in the left caudate nuclei. Demonstrates, you can appreciate the cyst over here with some areas of gliosis around it, extending up to the head of the caudate nucleus. And so predominantly involving the caudate nuclei, no restricted diffusion per se, and no blooming on the SWI. The rest of the brain did not demonstrate any abnormality. I could not appreciate any abnormalities on the angio of the brain or the neck. So it looks like more of a late subacute or chronic change rather than a acute change, at least on the imaging. Would you agree, Dr. Ray?
Yeah. Even though the histories of a week, maybe he had it for a few weeks and became more prominent in a week. And there's no history of chicken pox or any immunization prior to this. So we did his no history of sore throat, nothing. So we did a ESR. ESO was normal. Echo was normal. Initially, I sent him. I sent him from my outpatient department to physiotherapy and told him to go home from there. And I put him on aspirin because I didn't have an answer. And I just said I'll just give him aspirin. And then as soon as he went, I just Googled because my rheumatic chorea was sort of in my differential and I've never seen a caudate lesion. And then I got a study done from Iran, I think, and same sort of lesion on the caudate. And then I thought maybe it is Sydenham's chorea with this lesion. And I sent him home on steroids. I called him back from physiotherapy, steroid for 2 weeks along with aspirin. And he was much better within 2 weeks. I don't have those videos now, but his weakness had gone. His movement disorder had resolved. So that was the interesting thing. So I didn't, in the previous rheumatic chorea patients, I think in one more, I had seen it, but I forgot about it. So maybe this is rheumatic chorea. But yes, I don't know. There must be a differential.
So at least on the imaging, what they have described in syndromes chorea, rheumatic chorea is involvement of the caudate in the dorsal striatum, also the subcortical and periventricular white matter, as you have seen in the images on literature. They have mentioned that this could be likely due to an inflammatory change or a vascular secondary small vessel disease. But I think to diagnose syndrome chorea, I think more of a clinical phenotype than the imaging would be helpful. The MRI changes are of small vessel disease involving the caudate or the dorsal striatum.
Unilateral small vessel disease, right?
Yeah, unilateral, yeah. At least in our case, and the image over here of ABCD panel, which was seen in this case series of.
Yeah, number ABC. So that's the paper I saw. I called them back and I started him on oral steroid, small dose oral, and then he's much better. In 2 weeks' time, his weakness had resolved, and his chorea had resolved, like that erythroid movements had resolved.
Okay. We'll open the case for further comments.
The question is whether this boy was better despite the steroids, or whether this was just due to steroids or the natural history. I did not understand all your comments, but in my, of course, limited experience, Sydenham chorea has normal imaging, so I'm very skeptical about this diagnosis. This is rather an old ischemic lesion, I would suppose.
Could it be vasculitis? You're saying small vessel disease, no?
Yeah, small vessel vasculitis, but not of the acute nature. It is more of a chronic change.
Okay. That would explain why it got better with the steroids.
Based on the imaging, I wouldn't be confident in calling it syndromes chorea. It is just a, I think, change of a small vessel disease, but a chronic change. If it has the clinical features of chorea, then I would probably correlate that with the imaging.
So he did have hemichorea. He did have hemichorea in spite of, and we have seen chorea paralyticum, where it has been for a few weeks. The whole, the child is not even able to sit or stand. It's more like hemichorea with hemiparalysis. So if it's been going on for a few weeks, your side gets weak also. Because see the contradiction that in spite of having that weakness, he could use his arm well, and when he did the pronated drift, the right arm didn't fall. It was the left which was going down. So that's contradiction is very suggestive of hemichorea. And he had a milkmaid grip, he had pronated drift. For vasculitis, so small vessel vasculitis, if one thinks, then yeah, primary CNS, it should be bilateral. It's not bilateral. And involving just the caudate is very odd. In children, we don't see CNS vasculitis that often, primarily, but just involving the caudate.
Primary vasculitis. I'm thinking of secondary vasculitis.
Secondary as to what?
Secondary to any infection. It could be even your Sydenham's chorea also. But the thing is, you said you did ASOT. You did not do anti-DNase B, right? You said ASOT.
That's the semantics. One can do that as well. Like, that can also be normal. But yes, that reflects of a longer course.
You say.
Right. Yeah. So, but in all my patients, whenever I've done it, somatic chorea, that was always normal as well. So usually it's a clinical diagnosis. Even the echoes have been normal in rheumatic choreas when they come with the neurological presentation, most of them. So I can do that, but just it's just odd to have a caudate lesion. One can think of vasculitis, and one can think of TIA, but TIA doesn't happen just in caudate. More often, it is more of a lenticostriate vessel.
Just one sentence. Hemichorea is just a descriptive term. It means unilateral. And this can be due to a structural lesion or due to an autoimmune process in the strict sense, like Sydenham. So even in large series of so-called Sydenham's chorea, about, I think, 20 to 30% present with hemichorea. So this is basically not unusual.
Yeah, Yogen, because we see it more often here. So you are right. Actually, if I have seen it more often, it has been unilateral chorea. So more often rheumatic, at least what I have seen, it comes with unilateral. And if it has been not identified, then it moves on to lead to chorea paralyticum or significant bilateral chorea. So it's much more than even 20%. And it's just a contradiction of weakness, but not that much on clinical sign, which makes you think of hemichorea.
All right. Okay. If there are no further comments, we'll move on to the next page.
Nihaal, any other differential?
Yeah, sorry.
Like,
in fact, only involving the caudate, again, slightly unusual. No, I cannot.
the other reason I want to sort of present it now, we should start thinking of this as everybody says, small vessel vasculitis. This is more of a vasculitis. It's not really.
Yeah.
People in the past haven't given steroid up front. They just give valproate to improve the chorea. But what we have seen is steroid makes it dramatically better within weeks. And one shouldn't be hesitant to use it if it's causing significant functional affection. Because it probably is a vasculitis, unilateral vasculitis.
Yeah, vasculitis, I would think so. Yeah, but the cause of the vasculitis, I think, are varied. So that will depend upon the clinical presentation.
So,
this is just a table of the various causes of chorea. I think since you have mentioned there's possibility of the immune-mediated syndrome chorea and the causes of chorea just for reference.
we also did a EPLA workup, which was negative. I didn't write it there, and ANA that was negative.
All right, thank you. Move on to the next case. Next three sets of cases are from Dr. Juhi, so Dr. Juhi can take over.
Good evening, everyone. Am I audible?
Yeah.
Okay. So the first case is a 12-year-old female child, and she came to us for the first time this month, and she is symptomatic since the age of 6. The father is in army, so can give us a good history, and the history was on and off headache and focal seizures, left focal seizures. And when the child came in, we had a MRI brain which could show us a lesion. But then the child came to us with a severe cervical pain which was not responding to even opioids. So then we had to take up cervical imaging, which also revealed findings. So we wanted to know the nature of lesion.
Just before going to the image, was TB ruled out? There are no clinical features of TB, but
since the history is from last 6 years.
Yeah, 6 years. Okay.
And the child never received ATT. So to have TB and to survive for 6 years without ATT was, plus the imaging features were favoring more of slow-growing tumor.
Yeah.
So it was reported as TB actually, but many a times the government reporting is not up to the mark many a times. So TB was very low on the cards.
Okay. Yeah. So I'll go ahead with the images. This was at 12 years of age. We have the axial images focusing on the temporal lobes, and you can appreciate that there is a mass in the right temporal lobe with a cystic lesion and a solid component. It is expanding the temporal lobe. There is very minimal perilesional edema seen on the FLAIR images. You can appreciate the cyst along the anterior aspect. It is iso-intense to slightly hyperintense as compared to the adjacent cortex. FLAIR again is slightly hyperintense, extending up anteriorly. T1 again it demonstrates iso to hypointensities. No significant enhancement on post-contrast study. So at this point, I would think of a glioneuronal tumor given the imaging findings. But then if we go on to the spine images, were they done at the same time, Dr. Juhi? I mean, the same, the age of 12 years?
Yes.
Yeah. So in the spine, you can appreciate diffuse leptomeningeal deposits extending from the prepontine system, interpedunculaar fossa, suprasellar system, all the way up to the lumbar spine. So extensive leptomeningeal disease demonstrating contrast enhancement, and on the post-contrast axis images, you can appreciate that these there is diffuse electromagnetic enhancement causing some reduction in the cord diameter. So based on the imaging, MR, brain imaging, and the spine imaging, I thought of a possibility of diffuse glyoneuronal tumor. There's no CT or SWI images to see if there's calcification or not, but this is a recently described entity for diffuse glyoneuronal tumor with oligodendroglioblastoma-like features, and the brain imaging features are relatively similar to what is seen in our index case. There is relatively less perilesion edema, it's isohyperintense on the T2 pair. There is negligible enhancement, and internal calcification can be demonstrated. The other entity, what I thought was, though it is slightly atypical for the DLGNT because they usually present with these prominent subpile perivascular spaces, there can be case reports as presented in this paper by, I think Dr. Mankad was there in it, and here you can see that you have a isolated focal parenchymal lesion and also leptomeningeal disease. They can also present with solitary spinal cord tumors. So even though this is the more typical form of the DLGNT, they can also have parenchymal lesions with leptomeningeal disease accompanying it. So based on the imaging, I would think of the glioneural or neuronal tumors with a diffuse pattern of presentation.
Okay, so the child did have calcifications on CT.
Okay.
Similar to the image shown, I could not submit the CT, but there were calcifications. Also, after submission, the father also came up with the prior images. And there were around 3 MRIs. All 3 had the similar brain lesion. Spine was never done. I think it was later got spread to the spine, but calcifications were there.
Okay, so that will favor the oligodendroglial component. The spine can be part of the lesion or it can be metastasis also.
Okay, so any suspicion of any infective etiology or tubercular?
No, this the brain imaging pattern is not typical of TB. There would be some contrast enhancement. The intensity is also slightly atypical to a TB. It is more hypointense on the T2-weighted sequences and doesn't have a solid and cystic component separately. And then there will be some enhancement on post-contrast study, either a ring-like enhancement or some degree of enhancement would have been there. This is more of a mass lesion, I would say neoplastic lesion.
Right.
And I would go ahead with the biopsy. Either a meningeal biopsy or the temporal lobe lesion.
Right, right. Okay.
Okay, if there are any further comments, I'll open the case for discussion. Okay, if you don't have any comments, we'll go ahead with the next case. Again, Dr. Juhi.
Okay, so these are 2 siblings, and I could submit the image for the brother. So a brother and a girl. These are the only 2 kids, non-consanguineous parents, and they both have a similar history. So the boy is now 10 years, the girl is now 4 years. So the history for the boy is that there was regression by 4 years of age, and how the regression started, that initially child started having hyperactivity. Then the parents say that he did not used to go around much in the night. So there was a history of night blindness more, and then progressing on to day blindness as well. And then gradually the motor skills started to decline. So behavior, vision, and then motor decline, leading to a bedridden state from last 4-5 years. So currently the boy is bedridden, malnourished, and clinically does not have much of a spasticity. And fundus shows optic atrophy, and the reflexes are brisk. The younger sister, who is now 4 years of age, around the time that the boy became symptomatic, so again she is started to get similarly affected. So the girl has started to have some vision problems, again more in the night, and has started to have some behavioral issues, although there is not much of a motor decline yet. And the girl also had some hepatosplenomegaly, but that was with acute fever, so that may not be related. And the fundus for the girl, initially it was reported as retinitis pigmentosa, but then we got it repeated, and they were actually hypopigmented spots. We could see whitish spots throughout the fundus, multiple spots. Did a literature review. Sometimes it can be reported in immunodeficiency, acquired or inherited, but hypopigmented spots did not get much of a clue. So genetics has been already submitted, and these are the scans, interval scans of the boy.
Yeah, thank you. So this is at the age of 6 years. We have T2-axial images, and you can appreciate concurrent white matter changes involving the bilateral cerebral hemispheres, more along the periventricular regions in comparison to the subcortical white matter, which is relatively spared. Coming down to the deep gray nuclei, at least from the FLAIR images, you can appreciate the central white matter is also involved, but the thalami demonstrate these hypointense changes on both sides, predominantly in the ventrolateral aspect. There is some prominence of the lateral ventricles. I did not have the posterior fossa images, but this is again at the age of 10 years, that is 4 years from the first scan. Then you can appreciate that there is an interval demonstration of parenchymal volume loss, a form of neurodegeneration. The white matter changes are still persistent. There is also extracted dilatation of the ventricles and the CSS spaces. Again, the thalami has reduced in volume, demonstrating these hypointense changes also can be seen in the global parallel. Brainstem now demonstrates these hyperintense signal changes and also can be seen in the cerebellar white matter involving the dentate and the dentate nuclei. The corpus callosum is reduced in volume, and also the brainstem is also reduced in volume. The vermis is also reduced in height or hypoplastic. So an overall appearance of periventricular predominant white matter changes. These are the differentials which you think of when you see this pattern. MLD is the one of the common diseases presenting with this condition. And then the pattern of white matter changes is corresponding to the demyelinating pattern of leukodystrophies that can be seen in these disorders. And the hypointense thalami are usually seen in the storage disorders, such as the lysosomal storage disorders. And the cerebellar white matter changes can also be seen in the storage disorders such as Krabbe's disease and other inborn errors such as enteroheterocyclia, Wilson's disease, etc., and also can be seen in MLD. So based on the imaging pattern, I would think of lysosomal storage disorder, MLD as the first differential, and to also evaluate for other storage disorders. At this point, I'll open the case. Share up, please. Sorry.
Why not NCL?
NCL, the white matter changes are not as significantly seen. They present with periventricular white matter changes, and also in the subinsular region, but the confluent nature is slightly atypical for NCL. I did not have the posterior fossa changes in the first scan. Cerebellar atrophy is seen, but at the age of 10 years, you can appreciate that there is generalized parenchymal volume loss, which can be seen in any disorder on the end stage. So NCL comes under lysosomal storage disorder, so I would evaluate the storage disorders as a whole, but I would think of MLD of Krabbe as first possibilities, and also NCL can also be evaluated.
So this
any optic atrophy or anything?
So the boy has a
optic atrophy. Okay.
NCL, there are some juvenile forms wherein the white matter changes as well as split changes are described. However, the brainstem changes are not described. Then given the history is a bit odd for a leukodystrophy. For years, although it can be there in many leukodystrophies that there are behavioral changes to begin with, but these kids have vision loss and behavioral changes for like 1.5 to 2 years before having a motor decline. There is hardly any spasticity. For lysosomal storage disorders, I'm afraid, but NCL does not come under lysosomal storage disorders. So lysosomal storage disorders, there is no organomegaly, no cherry red, no mongoloid, although again, these changes, these are not strict. But my first differential was gray matter DBD. Gray matter degeneration.
So Juhi, Vivek here. So, this pons shows a hot cross bun appearance. So that was described by one of the doctors in Jaipur in CTX. He said cerebrotendinous xanthomatosis. He described it, Dr. R.S. Jain, I know his name as well. So I was, is it looking like hot cross bun, pons? So
hot cross bun would be like this. The hyperintensities will not be seen. So it will only be a linear form of hyperintensity.
Because CTF, sorry, yes.
Can I make 3 comments? I mean,
you can, yes.
the MR at 10 years is kind of a burned out stage, and this is less helpful than at the beginning. And the hot cross band sign is non-specific. I support Nihaal because of the tigroid pattern and the almost lack of cerebellar involvement initially. NCL is very low on the list. And in terms of clinical comment, you mentioned that this child is hardly spastic. So the question is, has he a polyneuropathy and areflexia, which is a common combination with MDL? So did you measure nerve conduction velocity and how are the reflexes? Just comparing to Krabbe disease. Krabbe usually goes along with large chiasm and optic pathways, anterior optic pathways. And also in terms of prevalence, at least in Europe, MLD is much more common than Krabbe.
Both the knee and the ankle reflexes are brisk.
Did you measure nerve conduction?
So, yes, so in the nerve conduction study, there was mild reduction in the amplitudes in the C-maps, but the child was very wasted. So the muscle mass itself was very low. We can do it for the younger sibling. We can do it for the girl. However, her reflexes are brisk.
But your conductions and distal latency was normal, right?
Yeah, that
so
was
that
fine.
is very odd. That will be odd for a demyelinating disorder, right? This is more of axonal, if anything, or muscle wasting.
Right.
So,
Would
yeah,
MLD have a so these, I saw the fundus myself and they were very classical hypopigmented spots. So I was wondering, would MLD present upfront with vision loss and these fundus changes?
MLD is a white matter disorder and the axons in the optic pathways are involved. So this leads to early optic atrophy. This is not very special for me.
Okay. And such significant cerebellar involvement, do you see it in MLD?
Not initially.
Yeah, so that is
initially, but no, this is at the age of 10 years. This is after 4 years of the initial scan.
Initially,
you will do genetic testing and then we have an answer.
Right, it's already submitted.
CTX is a definite possibility here, significantly, like it's a very important possibility because of the cerebellar changes and the pons.
So, just in CTX, the intensity of the white matter, the changes are slightly different. It is hypointense in comparison to the hyperintense changes. There's a degree of hypointensity there in CTX, whereas this is uniformly hyperintense. Just on the imaging, it can be possible, but
okay. So I got the point. So the interpretation of scans at burnt out stage is not that important as compared to the initial. I got that, and I'll update with the genetics.
Yeah. All right. Thank you. Next case, Dr. Juvi.
Okay, so this boy came to us with a history of a subacute onset progressive hemiparesis of the left side, along with headache and vomiting. There was clearly no history of any recurrent TIAs or recurrent strokes or any cognitive decline or any focal epilepsy. The history was of a hemiparesis, which is progressive, but not suggestive something like Rasmussen's or mitochondrial. They say that it was gradually progressive. And when we saw the scans, it could corroborate. So wanted to confirm.
And this is only one hit, no recurrent clinical symptoms.
No. So as per them, 6 months say there is a hemiparesis which is increasing day by day or month by month. And however, mental function is still quite preserved and no seizures.
Okay. So we have the MR images. This is at what stage, Dr. Juvi? This is after 6 months?
Yes. These are the current scans. They've come for the first time.
All right. So on top you have the T2 and the flare images, and you can appreciate confluent predominant white matter changes involving the entire right cerebral hemisphere. They also involve the corpus callosum. The corpus callosum is also slightly thickened due to the infiltration of the white matter changes, and it is extending up to the contralateral frontal lobe and the parietal occipital lobe. The brainstem also demonstrates these abnormal signal changes. On FLAIR images, there were some cystic changes in the frontal lobe. Sorry. Yeah, see, only small cystic change in the frontal lobe, but otherwise the white matter demonstrates these hyperintense signal changes, no significant cavitation or rarefaction. Diffusion, could not appreciate significant diffusion, but there were some linear areas of restricted diffusion, or probably this is the spared cortex. As you see on the contralateral side, the signal changes are similar to the what we are seeing on the perisylvian region. So I think the white matter demonstrates no restricted diffusion. There is some area of peripheral areas of restricted diffusion in the brainstem lesion, and probably the mesotemporal lobe demonstrates some high signal changes on DWI. I did not have an ADC. These are the top. The top are the plain T1 weighted images, and the bottom is the post-contrast images. Again, on T1, you have these hypointense signal changes. The gyri demonstrates slight T1 shortening, possibly due to necrosis, laminar necrosis, and again, cystic change in the brainstem. Post-contrast cannot appreciate any significant enhancement. Unfortunately, I don't think this child had a spectroscopy. Am I right, Dr. Julie? At least it was not there on the scan.
I think he did, and there were some choline peaks. I'll just check that. I think he did have
Okay,
an MRI.
right. Okay, it was not there on the file, but anyway, these are the possibilities which we are thinking of. Diffuse glioma in the gliomatosis cerebri pattern, because it involves more than 3 lobes and it is in a contiguous pattern. Gliomatous cerebri is now just an anatomical description. It is based on the diffuse glioma. If they are present with more than 3 lobes, then we describe it as a gliomatous cerebri pattern, and it's most commonly in adults but can also be seen in children. This was a literature review done in 2015 where they had found the patients with gliomatous cerebri in 88 children. This also reminded me of a case of Dr. Vivek, who just presented in the last meeting, GFAP astrocytopathy, but the contrast enhancement is more, as you can see, is more intense and homogeneous as compared to our case, but that doesn't rule it out, but it is less likely in comparison to a glioma. Other possibility I thought only on imaging is a leukodystrophy type MOG antibody-related disease, but clinically it does not match. The initial differential I would think of is a diffuse glioma. At this point, I'll open the case for further discussion.
All right.
I agree. This is the most likely diagnosis and extremely difficult or not treatable.
Yeah, I think the prognosis is very bad if it's of a diffuse glioma.
Okay, thank you.
Next question, Dr. Rashmi. Dr. Rashmi.
Okay, yeah. So this is a 2 or 4 month old child who presented to my clinic with left hemiplegia, mild global developmental delay. And he was born by emergency C-section, mild hypoxia, but he cried immediately after birth, no NICU admission. He had early hand preference of the right side. And now he's just joining 2 words together. And he had increased tone in his left hand, left leg. Reflexes were brisk, plantars were extensor, mild squint, and dystonic posturing of the left leg while walking. So, so we did the MRI, and it was quite expected to see perinatal stroke, but I think it's quite interesting. So, what did you find, Dr. Nihaal?
Yeah, thanks. So the MR on the top is the T2 axal sequences, and you can straight away appreciate that there are these gray matter indentations going into the lateral ventricles, occipital horns on both sides, the left more than the right. So these are suggestive of periventricular nodular heterotopia. Maybe some degree of volume loss in the frontal lobes, but other than that, I cannot appreciate any other structural malformations. There are few prominent perivascular spaces. This is a very non-specific finding. Posterior fossa, no dysplasia or any signal changes. You can appreciate the nodular heterotopia more clearly on the coronal T1 weighted sequences over here. So left more than right. Corpus callosum, brainstem, and cerebellar volume demonstrates normal appearance. Nothing, no calcifications or hemorrhage on the SWI. I'm not sure why the MRA was done, but there's nothing on the MRI angiography. So radiologically, the diagnosis would be of a periventricular nodular heterotopia. So these are the different gray matter type heterotopias. Based on the location of involvement, they can be subdivided into subcortical, transmantile. Periventricular, if seen in girls, it can be linked to the FLNA mutation. I think Eigen has a publication of a large series of patients with FLNA mutation, can present with motor disorders and have ARF-GFP mutations. Ribbon-like pattern can be seen in EML1, and brain-in-brain pattern can also be demonstrated. I think the question was this, as a clinical presentation of hemiplegia, I could not find any causes of any findings of periventricular nodular heterotopia associated with hemiplegia. This is a recent paper, I think 2019 review paper, and they only found that hemiplegia was seen in the periventricular nodular heterotopia in the COL4A1 mutation, but other changes such as porencephaly, shyencephaly are not seen in our case. It is an isolated finding of PV and H. So I'm not sure of the clinical correlation with the imaging findings.
See, our radiologist was saying something about in the right insula there is a heterotopia, something like that. Is there anything in the?
No.
No. Okay.
At least not on the images.
Nihaal, I see the heterotopias, but the heterotopias don't explain the clinical left-sided hemiplegia. And for me, overall, the volume of the right hemisphere on upper axial and on the coronal slice is of reduced volume. So this is, I think this is responsible for the hemiplegia in the broad sense, although it's not a typical finding. But my suggestion is that this was an antenatal diffuse event resulting in smaller volume of the right hemisphere. And the heterotopias are there, don't explain the clinical situation.
Mm.
Can you see my point?
Okay.
Is it because of the cut, Dr. Nihaal, the way the cuts are taken, or is it small?
I think so, because I'll review the scan later on, but at least on the images, it looked, there's generalized volume, there is volume loss, but I could not appreciate a right more than left. But there would be some
on the very left image.
This one, yeah.
Definitely an asymmetry, and this is good quality axial scan. And also on the lower coronal, there is an asymmetry.
Okay. Yes.
Nihaal, is there in the superior frontal gyrus on the left side, there is suggestion of cobblestone lysencephaly polymicrogyric pattern just on the top on the left, and also in the second row, second coronal section, again the sagittal, the front, superior frontal gyrus on the right side.
So these are actually the parietal lobes.
On the right,
not the frontal section. No, I think that is just the cut which we have taken.
Okay.
That wouldn't explain the hemiplegia. It is the lysencephaly, or if it was there. So I can see what Eigen is saying. That is a very non-specific finding.
Very non-specific. Okay.
Yeah, there are more than 20 conditions presenting a perivascular, prominent perivascular species. But I can see what Eigen is saying. The white matter, if you see on the right, is less than the white matter on the left. Was this congenital hemiplegia?
I think he's talking about perinatal, some sort of perinatal hypoxia.
So was the hemiplegia from birth, or?
Yes. No, it's early hand preference, no? So it's from the age of 6-7 months they've noticed.
Okay. Okay,
so the heterotopia is incidental.
Yeah, I think the heterotopia is incidental. Would you agree again?
I don't understand. Say it again.
The heterotopia, is it just an incidental finding?
Yes.
Yeah. Okay. And would you suggest genetics, or is it not required?
They don't explain the clinical situation.
No, they don't. No.
But Nihaal, you don't think that the topmost left frontal gyri?
You mean this part?
Can you? Your arrow is not showing. Which one? No. Left. Yeah, extreme left. Extreme left.
Okay.
Yeah. Those top two gyri.
Yeah.
This
I
one
would
and the one
actually.
to the medially as well. The one medial to it. Yeah, this one. These two. And that will explain the hemiparesis, but not the dystonia, because it's on the opposite side. So these three gyri don't look normal as compared to the rest. To me, like, and compared to the left side.
So at least radiologically, I would put it in two planes, but I'll have a look again. Because on a single plane, I usually don't comment on a malformation or a dysplasia.
Because cortex looks also thicker. Sometimes when you have perivascular spaces, that side malformation is always a possibility. Just a thought.
Yeah, it is. Yeah, but here it is also present on the contralateral side. So I'll have a look again, Rashmi, and just see if this.
Oh, okay. Thank you, Dr. Nihaal. Yeah.
Thank you. Yeah, next case again.
So the second one is a 3.5-year-old child. Actually, this was referred by Dr. Lakshmi. I think she must also be there in the meeting. So with focal seizures, the seizure semiology was eye deviation to the right. The head was flexed, right-sided mouth deviation lasting 2 to 3 minutes. Initially, I started the child on levetiracetam, and after that, they had different kinds of seizures. They said that she's just having staring episodes, almost like absence, blank spells. So I started the child on valproate. Otherwise, the baby is born of second-degree consanguineous marriage. Development is completely normal in this child. I did an EEG, which background was normal, and there is bilateral temporo-occipital sharp waves, left more than the right. And 16% of the sleep recording is abnormal with these temporo-occipital sharp waves. So I thought clinically this was neonatal hypoglycemic brain injury, but I think something else came out. So I thought, let's discuss the scan.
Right. So on top of the T2 weighted sequences, and probably here, in comparison to a previous case, you can appreciate the lissencephalic pattern. You can see the thickened pachygyric appearance of the anterior and the parietal regions with an anterior to posterior gradient. You can see that the occipital lobes are relatively spared in comparison to the frontal and the temporal lobes. I don't have a section of the basal ganglia, but it was normal. There were no features of tubulopathy. The white matter volume is slightly reduced. And also on the sagittal image, you can appreciate you can see the lissencephaly is more along the anterior aspect as comparison to the occipital lobes, which is relatively spared. The corpus callosum is also slightly dysplastic in morphology. Brainstem slightly reduced in volume, but not significant. Vermis is minor inferior vermis hyperplasia. Again, you can appreciate the frontal lissencephaly in comparison to the parieto-occipital regions. There are a few prominent medullary veins, but not of significance. So based on that pattern, I would think of conditions of causing lissencephaly. The anterior to posterior gradients can be seen in these genes. P6 is the most common gene, whereas the posterior to anterior gradient is seen in this one and other tubulopathy related genes. This is again a paper on the genotype-phenotype correlation of lissencephaly. If we go ahead with this box pachygyria or agaria with an anterior predominance, it can be seen in DCX or PRAD mutations, or a posterior predominance can be seen in LIS1 mutations. So I would think of these differentials for this case.
Very interesting. Again, it doesn't explain her clinical symptoms. But
there is no volume loss to suggest a neonatal hypoglycemic brain injury. At least the cortex is the sulcation is normal, not widened. At least I could not find any sequelae of hypoglycemic brain injury, but definitely a genetic abnormality.
Yeah, but she's got different kinds of seizures, so it could be that. Yeah.
Okay.
Something else I wanted to ask about.
The normal development is positively surprising, but this is no doubt malformation of development of genetic origin.
Yeah, she's pretty smart actually, this girl. So, Dr. Nihaal, can you share that paper with me, the one you showed about listen carefully?
Yeah, definitely.
Yeah. Thank you.
About 2 years ago, there was an extensive paper in Brain about kind of an update and a summary of what they call malformations of cortical development. I think Rossi was the last author.
Who was last author? Sorry?
Dr.
Ross.
Yeah.
Okay.
It was published in 2020 or 21. I'll share that paper too.
Okay, thank you so much. Thank you.
Next is Dr. Dashat.
Yes, sir, I'll present, sir.
Okay, yeah, go ahead.
Yes, sir. This child was a 9-year-old child, female child, who is a known case of a left congenital hemiparesis with refractory seizures, which were focal onset. And she was on multiple anti-epileptics, and she presented to us with acute febrile encephalopathy. She just had a fever for few hours, followed by altered sensorium behavioral issues. And within few hours, she became drowsy and complete encephalopathy. And at referral hospitals, there were like poor respiratory efforts for which she was intubated and ventilated. She was there for 2 days, and in view of poor response, she was referred to our center. So when the child came to our center, there was a quadriplegia, which is element type, and there was a ophthalmoplegia was there with restricted eye movements. And also during the hospital stay, she also had focal seizures and required prolonged ventilatory support. And also a few of the systemic issues she had was hepatic involvement, autonomic disturbances, and also thrombocytopenia. Initially, with the such acute rapid febrile encephalopathy and all, we thought of any toxins related or vascular and also A&E type. So we have sent the infective workup, which came as negative. And also gradually, like because of this encephalopathy and element type, we thought of even like because of encephalitis or GB syndrome. But the initial NCS was showing a non-length dependent axonal neuropathy. So first we have got an MRI done. It was showing a ALE-RD picture. But after giving IV steroids and also the IVIG, also child did not show any much improvement, and she had on and off seizures. That encephalopathy was persistent. And also the workup for other vasculitis and A&E profile, everything was negative, sir. And repeat NCS, when we have done, it was showing a diffuse axonal neuropathy, and repeat MRI within a gap of almost 1 week, we have done, it was showing a decreased changes. Yes. So here
So
we have
with dengue?
No, sir, dengue was negative.
Okay.
No, negative, sir. Workup was negative. Okay. So here our question is whether these changes can be correlated with the MRI changes and experience with the experience of other people with such cases.
Okay. We'll have a look at the MR.
Yes.
So initially the child, because it was suspecting of a GBS syndrome, the child came for a spine MR. So spinal cord, there was no abnormality, no enhancement of the corticoid nerve roots on post-contrast study, and no spinal cord lesions. At the same time, on the spine, we found few changes in the brain, and we did a brain study. And this is the diffusion on top with the ADC. As you can see, there is a confluent subcortical areas of restricted diffusion. Some sparing in the frontal regions and the parietal regions, but these correspond to gliosis, which are shown on the T2s and the flares. So again, if you come posteriorly, the temporal occipital lobes again demonstrate restricted diffusion in the peripheral aspects of the brain. Posterior foci is relatively spared in terms of the diffusion changes. Nothing in the deep gray nuclei. There is some doubt of a periaqueductal region hyperintensity on the diffusion weighted sequences, but it did not correspond to a low signal on the ADC. The flare images, you can appreciate old or gliotic changes in the right anterior and parietal, right anterior frontal and parietal regions. Some edematous changes as seen on the diffusion weighted sequences. Posterior fossa relatively spared. Corpus callosum demonstrates normal signal changes. Again, the edematous changes in the subcortical cortical regions. Post-contrast study do not appreciate any enhancement. These are just prominent vessels because of the edematous changes of the subcortical cortical regions. Scan done after 6 days demonstrates again high signal change on the diffusion weighted sequences, but almost a pattern of pseudonormalization in the ADC sequence. There were some areas of low signal change on the ADC in the superficial white matter on the left cerebral hemisphere. No new change. The only new changes which we found were these areas of restricted diffusion in the flicks on both sides, and they correspond with these flare hyperintensities. But the rest of the changes were same. Spectroscopy was done, demonstrated mild lactate peak, the mild choline peak, but this is very non-specific. At that point, based on the two images, we thought, especially on the first image, we thought of a possibility of ALA-RD. The other possibility was, we thought, like, at least on imaging, was a febrile infection-related syndrome, but less likely given, I think, doesn't correlate with the clinical presentation, but this pattern can be seen in files. And the last differentials were toxic or metabolic disorders or toxic related changes. At this point, I'll open the case for further discussion.
For me, can you go to your first text slide?
Yeah, this is the first. Right.
Oh no, after the MR.
Sure.
Yeah, I think this, for me, on balance, I mean, this is a descriptive term. This is the most likely diagnosis. And this is superimposed on this child with hemiplegic cerebral palsy, where you see, by the way, this is not important now in the context, a smaller right hemisphere correlating with the left congenital hemiplegia.
So we have the MR pattern, but the question was what is causing the MR imaging pattern of ALA-RD? Infection workup was negative, and I think we did not find any toxic causes. Is that the question, Geeta?
Other question is the acute, very hyperacute presentation, sir. Within 2 hours of a fever, presented with a deep encephalopathy and having all elements eyes with ophthalmoparesis, hypotonia, and absent DTR. And nerve conduction studies are also showing severe motor axonal neuropathy. So initially we thought of a bigger staph encephalitis and
was later in the course probably kind of critical illness polyneuropathy. But at the beginning, as you, I mean, just I'm reading acute febrile encephalopathy. This sounds more of an infectious nature, and of course, in at least half of the viral encephalitis, you don't find the causative agent. So this is not really particularly surprising.
Okay. By day 3 of intubation only, we could find those element signs. Is it possible in critical illness neuropathy to have such severe motor axonal neuropathy by day 3 of ventilation?
But in terms of hierarchy, I mean, what is important is now the involvement of the brain.
Yeah.
And this is very extensive and explains the clinical situation quite well. Well, what is your alternative hypothesis?
Can those brain changes are explained with a hypoxic injury when child was having a respiratory failure before intubation? Actually, it was intubated in the outside hospital due to poor respiratory efforts.
Moreover, I think I'll just tell a few more things. The other alternative diagnosis, what we were thinking here is, can this be one of the channelopathies like CACNA1A, which can present with acute brain edema like this? But the odd points here were the neuropathy, which was quite present early on into the disease course. Our other alternative hypothesis here was whether this could be autoimmune encephalitis, but we do not have a positive results for it. I mean, ESR was quite high in this child. ESR was 90, so that was quite high. But everything else, workup-wise from autoimmune point of view, were negative, and there was no response to immunotherapy. That was also odd. She's 3rd week into the illness, and she's almost similar how she presented.
Did you check for H1N1?
We didn't. I think we didn't check for H1N1 as such. No, we did not.
That's so rampant at the moment, and we've had already few patients with significant CNS involvement. So one has to, at this time, at least in North India, I don't know about Hyderabad. So H1N1 should be checked.
I mean, not came across any H1. I mean, I don't think so. We are testing more often right now, but maybe it would be worth testing. But the neuropathy, the element type of weakness which was present is again odd for any infective etiology as such. We were so.
See, it's an axonal neuropathy. So axonal is either toxic or metabolic, right? So toxin,
yes.
So acute, MODS like presentation, multi-organ dysfunction can have sort of axonal neuropathy, severe axonal neuropathy. And the other thing I wanted to ask you, Nihaal, you were mentioning LRAD. Can you go to the next slide? Next to the MRI. So is the white matter restricted? Diffusion it's more the cortex which is restricted, right? So when one says LRAD, is it more the white matter which should be diffusely restricted and some cortex?
Yeah, if you see on the ADC, this is the cortex which does not demonstrate low signal changes. So the white matter is
DWI.
Yeah, but we have to correlate that with the ADC sequences. This is, I think, the subcortical white matter just showing some partialing on the cortex, but that needs to be correlated with the ADC, and the low signals are predominantly in the white matter and not in the cortex.
Subcortical white matter, because usually with LRAD, with such severe LRAD, the white matter should be significantly affected, and especially with refractory seizures, not just the subcortical or the cortical, right?
Yeah, the subcortical white matter is affected here, so that can be seen in the dark signal changes. But the cortex you see over here is gray. I mean, is isointense or gray. So there's no signal drop in the cortex. So this is just
what my question was, in LRAD, should it not be that the whole white matter should be diffusion, whole or significant amount of white matter should be diffusion restricted, and the cortical or subcortical white matter should be less? The third image in your the third one. This is how typically it presents. This one doesn't show.
If you see the ADC, the entire white matter is showing signal drop, going almost up to the juxtaventricular region.
But not much as much in the DWI. So is it like later on we have done the images? Is that how it is?
No, this is the same time. This is the DW and this is the corresponding ADC.
Yeah. Okay. Just second image, first and second is the white matter, which doesn't show the diffusion restriction. Top 1 and 2.
Yeah, it is in the subcortical region. But
just
it is in subcortical. So ALRD is predominantly in the subcortical only.
Okay.
Predilection is predominantly in the subcortical. Okay. It's predominantly subcortical.
Fine. And the child has not been on any arsenic. Sometimes they take other medications for treatment.
No, I don't think so. She was on any alternate medication. For refractory seizures, the only new medication which was started 2 days prior to the presentation was oxcarbazepine.
Okay.
And she was given some glycine supplements as well as by another neurologist. But I don't think so we have any literature regarding whether that can cause a toxic effect or something of that sort. But that was again for a very short period of 2 days before she presented. So we don't have an overarching diagnosis here, even despite of extensive investigation. So we just wanted to know the thoughts from other team members as well.
Dr. Nikhil, you have raised the possibility of channelopathy CLC2. The only thing which is favoring that is the involvement of the clicks on the follow-up scan.
Okay.
But the initial presentation does not is not commonly seen in the channelopathies, which demonstrate myelin localization. But the pyramidal tracts or the clicks are usually seen in the CLC2 related disorders.
Okay. Okay. Right.
Would you be sending for genetics? Is that the idea, or just the?
We haven't sent the genetics as if, because I mean we do not have a clear phenotype as such.
Yeah.
So whether this is acquired versus genetic, that is the biggest question here. Or this is genetic with some precipitation.
Yeah, because at least the diffusion changes are not progressed compared to the first time. You see the signal drop is not as significant as the initial. If it was a genetic abnormality, I would think it would still persist, given the duration of 6 days.
Pseudo-normalization of, I mean, usually the course of illness with these sort of toxic encephalopathies or acute leak encephalopathy with late restricted diffusion, I think the course usually they show progressively improving trend quite well on. I mean, she's now 3rd week into the illness with absolutely minimum signs of improvement. This is just almost the similar state what she was brought in. So, like clinically also ALEID course, I mean, she's clinically not following that course of ALEID.
Okay.
So, any other thoughts?
New plick sign, how can we explain, sir, in this case? New onset, that posterior limb of internal capsule on both sides.
Yeah, that was the only point. So I think the myelin localization, or is it just extension of the excitotoxic brain injury? Because there is no intervening hypoxia, there is no changes are not related to hypoxic injury. Only plick involvement.
Inflammatory markers are also not that elevated. Ferritin normal, IL-6 is 25. Like.
Okay, not certain, but Dr. Nikhil, are we going to get a follow-up, or you just want to wait and observe?
I mean, we're not sure. She's still in the hospital. She's ventilated. I mean, she's tracheostomized and ventilated now. But spontaneous breathing efforts and some eye movements, that is the only thing which is there right now. Apart from that, she is still kind of quadriparetic, areflexic, despite of whatever hypothesis and treatment we have done. So quite odd. I mean, because of initial medial thalamic changes, we did think of, I mean, just as a trial, probably we did think of thiamine deficiencies and treated with thiamine as well, with no response.
Okay.
Kind of little clueless here. Neurology.
Are stuck, and we should perhaps, in the interest of time, move to the next patient.
Yeah.
Yes, you can. Okay. Yeah. Right. Thank you. Dasha or Geeta?
So this child is a 7-year-old female child who presented with intermittent fever and headache for the last 2 months with loss of appetite and weight loss with strong family history of tuberculosis. So outside hospital, Monto was strongly positive, and the CT was showing hydrocephalus. So child was started on ATT, but in view of deteriorating sensorial, child was referred to our center. Here, when the child came, there was bilateral dilated pupils. They were not reacting. Complete restriction of extraocular movements were there, and also child continued to have this fever spikes and deteriorating sensorium. So the repeat MRI and CT was done, which will be discussed. But here, investigation-wise, initially outside the CSF was done, which was normal, and also CSF gene expert was done, was negative, whereas the gastric aspirate at outside hospital was detecting low with the indeterminate rifampicin resistance status. So here we have sent the gastric aspirate culture and all. The recently when we have done the CSF after 2 weeks, here it showed very elevated protein, more than 3000 with predominant lymphocytes. And the latest report we got is the CSF gene expert, which showed detected low levels of MTB DNases. So after doing the surgical intervention, also post VP shunt, child did not show much response. The ophthalmoplegia was complete, and bilateral fundus, there was a disc margins were blurred. So here what we want to know is whether initially when the child presented, except for the strong history, we did not have any handle. So any other differentials to be considered with such imaging, like any fungal or anything?
No, but clinically, what is your diagnosis?
Clinically, we were suspecting tuberculosis, but initially all were negative, sir, that, and
Okay.
child was not showing much response.
Okay. So TB first, but other possibilities can also be there.
Yes, TB was the first possibilities.
Okay. These are the external scans. We have selected images, and diffusion, I cannot appreciate any abnormality. There is some prominence of the lateral ventricles on both sides, a reduction in the parenchymal volume, no focal lesions, some plain hyperintensity in the periventricular region, but not very significant. I'm not sure if this is exudates or not, given the quality of the image in the interpendicular fossa and along the optic chiasm. Nothing on the cis sequences. Post contrast, I can appreciate leptomeningeal enhancement in the bilateral temporal occipital regions, possibly also along the ventral aspect of the brainstem, extending up to the interpendicular fossa. Bilateral MCS systems also demonstrate some degree of enhancement, leptomeningeal enhancement. Scan was this is a follow-up scan after 10 days, and you can appreciate that there is progression in the terms of the ventriculomegaly. There is a significant transepidermal edema. The CSF spaces is slightly dirty in picture, not clear as what you normally see. Flare, you have these diffuse sulcal hyperintensities, periventricular hyperintensities, ventriculomegaly. The hyperintensities are extending up to the posterior limbomedullary capsules, also involving the brainstem, relative sparing of the red nuclei and the cerebral peduncles. Again, CSF is not suppressed. There are hyperintense signal changes on the flare images. Nothing. There were focal areas of restricted diffusion in the single gyri and also in the cerebellar, left cerebellar region. Post contrast, again some leptomeningeal enhancement, some basilar enhancement also seen in the bilateral MCS cisterns. The zoomed in picture, you can appreciate the basilar enhancement. There was some degree of enhancement in the right. This is actually the left side. So the inverted image on the left cerebellar hemisphere, the tonsils. Also, leptomeningeal enhancement involving the brainstem, the ventral aspect of the brainstem. This is the most recent CT study. On top are the, I think these are post-contrast sequences, and you can again appreciate this basilar enhancement, extending into MCS systems and diffuse leptomeningeal enhancement also seen. The ventricular size is reduced in comparison to the prior MRI, but there is persistence of the periventricular edema. So based on the imaging findings, at least I wouldn't go into the clinical features, but the sulcal hyperintensity, these are the differentials, with infection being the most common differential. The leptomeningitis, which is seen in our case, as these are images from our case, and also conditions causing pachymeningeal and leptomeningeal enhancement. Predominant leptomeningeal enhancement, we must think of infection and inflammatory disorders. Again, differentials for CNS infections, tuberculosis, TB is the most common for the leptomeningeal enhancement, but other etiologies such as viruses and bacteria more commonly, and also fungal infections can cause leptomeningeal enhancement. So on the imaging, I would think of TB, but if the TB is not definite, think of other infections based on the CSF and the culture studies rather than on the imaging. And at that point, I'll open the case for further discussion.
Have we done any baseline immunological tests?
Yeah, no, ma'am.
As in to look at the counts and other things? Because if we are thinking of an alternative to TB, what is the immune status of the child?
In the first instance, the CSF analysis was normal, but even though clinically with a strong MON2 positive and having a family history of tuberculosis, with contrast leptomeningeal enhancement and mild hydrocephalus on the initial scans, we thought of tuberculous meningitis only, and we started ATT. But child was deteriorating, and then we started thinking any other differential. So at the time we did that MRI, which was showing increased hydrocephalus and increased exudates. So then we did LPA once again. So in that lumbar puncture, we got 3000 plus greater than 3 gram per deciliter of protein and elevated cell count with gene expert positive for TB at that point. And rifampicin resistance also detected. I think that was the reason why child was not responding for all 2 to 3 weeks of anti-tuberculosis treatment.
So have you now changed the ATT? Have you changed the drugs? Replaced rifampicin with something else, second line ATT?
Yeah, already child was started on a levofloxacin, but in view of poor overall status of the child with no motor response and complete ophthalmoplegia, child was actually sent to left to other hospital for further care, as we have given a poor prognosis for the child. This is the recent CT scan where you can see loss of cysternal spaces with severe cerebral edema. And actually, this is the not contrast CT. Even without contrast, you can see the exudates being highlighted.
Yeah, the clinical picture and the CSF analysis at a later date, and everything is quite corroborative for your initial suspicion, isn't it?
Yes, yes, that's what actually the initial CSF being very normal for that MRI. We have never seen a TBM with a normal CSF previously. Then we went to literature, then we found coccidiomycosis having the similar cysternal meningitis, cysternal exudates as in our child.
Yeah, but the clinical doesn't match, no, sir, with the fungal?
Yes, sir. Yeah, yes, sir.
No, I agree that leptomeningeal and bacillus exudates.
We repeated CSF analysis in the later stage. In that CSF, it was confirming tuberculosis.
Okay. Okay, so we have the diagnosis. All right. If there are no further comments, I'll move on to our next case in the want of time. Dashak or Geeta who's presenting?
Yes, sir.
Yeah.
This is a 2.5-year-old child, sir. Actually had a uneventful delivery, shifted to mother side. But after shifting to mother side, within 2 to 3 hours, the child started to have a seizures in the form of a tonic posturing and apneic episodes, and was encephalopathic in between seizures. So due to those seizures and apneic episodes and encephalopathy, the child was intubated on day 1 of life only, and had multiple episodes of seizures while on ventilator. It's all in outside hospitals. Child had good response with pyridoxine on day 2 of life. And MRI was done at 10th day of life, and which we'll see in the next slides. Now child came for follow-up at 2.5 years. Child developmental wise, now he is walking independently. There was some pseudobulbar dysfunction. Expressive speech delay is there. But cognition wise, he recognizes and interacts with parents, obeys commands. An examination, microcephaly is there, and pyramidal and extrapyramidal signs were there. In the newborn period, where there were a flurry of seizures on day 1, child was evaluated for infection and pyridoxine deficiency, which was normal. Homocysteine was also done, but report was not available. Urine sulfates were normal. Exome sequencing was sent at that point of time. It was showing FKRP compound heterozygous mutation, but on MRI, we thought of actually clinically we thought of sulfate oxidase or molybdenum cofactor deficiency. And the question is, any neuroimaging differentials for those MRI, and with that MRI findings, how to prognosticate further development. We actually, it was a positive surprise for us to see child with this much of improvement at 2.5 years of age.
Okay, thank you. And these are the MR images at day 10. Not very clear, but I think these are the diffusion weighted sequences, and they are confluent predominant white matter abnormality. I'm not able to distinguish between the deep gray nucleus on the diffusion, but the white matter changes are confluent on both sides. Again, the quality of the image on top panel is not very clear. This is the T1 weighted sequences. You can appreciate the edematous changes involving the bilateral cerebral hemispheres and the corresponding hyposignal changes, hypointense changes. There is some areas of T1 shortening in the cortex on both sides, predominantly in the parietal regions. Deep gray nuclei, the basal ganglia at least appear normal on the T1 weighted sequences. Slightly bright, the ventrolateral thalami is slightly bright. But again, the quality of images, I'm not very certain if this is a hypoxic change or not. T2s are more clear, and you can appreciate the confluent predominant white matter changes, but also involving the cortex. The cortex is also demonstrating reduced volume. So there's cortical thinning, diffuse white matter changes. Basal ganglia appear normal. No signal changes on the thalami. Brainstem also no signal changes. Cerebellum for 10-day-old is normal. This is the SWA sequences. I think these two foci are on the film and not in the scan. So no blooming on the SWA sequences.
Nihaal, can I ask, are these all MRI on the age of 10 days, or is that the
10 days. 10 days.
Thank you.
Yeah. So this was the gene result. FKRP, the heterozygous mutation stands for the alpha dystroglycanopathy. In literature search, I could not find similar abnormalities of the FKRP gene which correlate with the imaging findings. They are predominantly involve the cortex with malformation. White matter changes can be seen, but not as severe in our case. There is white matter and gray matter involvement. So imaging wise, I'm thinking of at 10 days. There was no hypoxia, Dashrath?
No, sir. No, sir. Actually shifted to mother side after delivery.
Okay. If the basal ganglia were involved, I would be more confident for a molybdenum cofactor sulfatoxide deficiency, but not necessary. They can also have predominant peripheral involvement, but we don't have the lab correlation for a sulfate or molybdenum. Is that right?
Yes, sir. But
Would that be,
homocysteine, if that would be more helpful. Sometimes
okay,
uric acid can be normal.
but would that be picked up on genetics? Because there.
Normally, it should pick up. We have given these clinical clues before sending genetics, but clinically, it's not fitting into FKRP gene.
Yeah, no. Even imaging wise, it doesn't fit in the scale. So I'll open the case for further comments.
So for other panelists, the question is depending on based on this neuroimaging, how to prognosticate in newborn period.
My
just before the panelists answer, sorry, go.
It would be helpful to have a follow-up MRI.
Follow-up scan, yeah, that's what I was.
The MRI, in my opinion, does not fit to a form of congenital muscular dystrophy. Whether would it be FKRK or Foucaultine or whatever. I mean, this looks like bilateral destructive lesions.
Yeah.
And does not fit to pyridoxine-dependent seizures.
Yes.
This looks rather acquired or whatever, but this is not a primary malformation as is the case in the form of congenital muscular dystrophies.
Yes, I agree that, after myelination, that after the age of 18 months to 2 years, a repeat MRI brain would be useful to see what it is showing currently. And then, because neonatal MRIs, it just changes. What you see at 10 days will all change depending on what was the cause and all that. So,
but with this extensive cystic changes, should we expect this amount of development in any child?
You need to repeat an MRI now and see.
Yeah, we need to repeat the MRI.
Yeah.
You cannot prognosticate on a 10-day child MRI.
Okay.
Was CPK
The gene also, no? It's heterozygous. So you need to test parents and see if they're carrying it. If they're carrying it, then it has no significance.
Was CPK normal?
Yes, sir. Yes, normal.
So that is where it just rules it out completely, isn't it? Because it's a congenital muscular dystrophy and
yes,
more
sir,
severe form.
we are not at all thinking about muscular dystrophy, sir.
You don't necessarily need parents to be tested because parents will have it, heterozygous form. So that doesn't mean this is pathogenic. It is the clinical correlation.
Yeah,
because
there is no clinical correlation.
Parents will have it. So that's not important. And the other thing is, you said the child was with mother and he ended up being ventilated. So there should have been some degree of hypoxia during that event. A child who got ventilated, who was with mother, apneic, tonic posturing. So the child was, as Yugen said, there must have been a acquired event, which we might have picked up a bit late. He was ventilated in view of apnea. So, there was a hypoxic event. And this fits because this child has pseudobulbar, he has more like a Worcester-Drought syndrome, secondary Worcester-Drought.
Yeah.
Involvement with spastic diplegia. And his MRI in newborn period also shows that, there is significant perisylvian damage.
Yeah.
So it fits.
And also many of the neonatal seizures, they, I think pyridoxine acts as a cofactor. They just respond. They're not pyridoxine dependent epilepsies. They sometimes just respond. Many times we see that.
Okay.
Follow-up MRI will be very important and helpful in further discussion.
Okay, sir. Okay, sir.
Okay, sure. Yeah, all right. Thank you. Sahil, please go ahead.
Yes, sir. So this is a 1 year, 5-month-old male child, born of 4th issue of non-consanguineously married parents with normal perinatal history. And there was global developmental delay which was present since birth. And he presented to us with complaints of vomiting, fever on and off, and multiple episodes of seizures in form of only uprolling of eyeballs lasting for a minute. And child had such episodes of 2 to 3 episodes. So when the child presented to us, the child was showing low GCS with acidotic breathing, and eventually the child was loaded with Levera and lorazepam. In view of low GCS, he was intubated with proper neuroprotective measures which were started, and the child was shifted to PICU. And their ABG which was done, which was suggestive of a severe acidosis of pH of 6.95, and urinary ketones were +4. So we went up and we did another metabolic workup in this child, which showed ammonia which was raised 169, and lactate level, although they were normal. So a possibility of metabolic disorder was being kept. So on examination, the child had microcephaly, intermittent dystonic posturing with brisk reflexes. So there is global developmental delay, there is acute deterioration which is present, and also there is metabolic findings which are suggesting towards neurometabolic etiology. So that's why MRI was done. And yes.
Before going to the MR, at least on the clinical presentation, what I could gather was child has hyperammonemia with acidosis and urine ketones. So I would probably go down the line of organic acidemias or disorders of fatty oxidation. To come back to the algorithm after the MR scans. So in the MR images, at what age was this done, Sahil?
The same age, sir.
1.5.
Yeah,
Okay.
1.5 years, the same.
So you can, yeah, you can appreciate symmetrical changes in the bilateral global paradi. They are demonstrating these T2 hyperintensities with corresponding flare hyperintensities. Nothing on the supratental vein parenchyma. Some degree of volume loss is there. On the diffusion, we have these high signal change on the DWI sequences, partially in the right midbrain. On the ADC sequences, there is some degree of low signal change or restricted diffusion in the bilateral global paradi. I cannot appreciate or tell certainly if there is low signal change on the right cerebral peduncle, but it compared to the contractile side, it appears slightly dark. So the predominant changes are bilateral global paradi changes. Spectroscopy demonstrated this lactate peak, and the rest of the peaks were normal or non-diagnostic. Corpus callosum is normal for age, brainstem, and the cerebellum is normal in terms of volume. So again, coming back to this flowchart, thinking of organic acidureas, these are the possible disorders and disorders of fatty oxidation. So on imaging, if we have symmetrical changes of the global paradi, these are the disorders one needs to consider. They are predominantly organic acidureas, but also respiratory chain disorders such as pyridoxine dehydrogenase deficiency need to be considered. And these are just further examples or differentials for bilateral global paradi changes, ranging from kernicterus to beta-ketothiolase deficiency. There was no deficiency of the creatinine, so creatinine deficiency can be ruled out, but rest of the findings, at least on imaging, to be kept in the differentials. At this point, I'll open the case for further discussion.
Sorry, did we get the metabolic workup back?
Urine organic acid?
So we have set GCMS and TMS. The report is awaited.
Okay.
And was there a hypoglycemia?
No, sir. The sugars were 210 at the time when he presented to us during ketosis.
Okay. Because with hypoglycemia, that will further narrow down your metabolic differentials. And there is a ketotic hypoglycemia.
No.
Yeah. Okay.
Okay, if no further comments, so I hope you'll get the answer and get back to us.
Yes.
You did a homocysteine, right? Homocysteine?
Homocysteine levels normal, sir. We have done it. It's normal, sir.
Okay, we'll move on to our next case.
Yes, thank you, sir.
Right, thanks. We'll be here.
Yeah, good evening, sir. So this is am I audible?
Yeah.
So this is a 10-month-old boy was born to 4th-degree consanguineous marriage, and the child came to us with the complaints of developmental delay. So when he came to us at 10 months, he had achieved neck control, but there was no rollover still. But he could approach objects like the fine motor function-wise. He was having unidextrous approach. And he was visually tracking and fixing. But the parents said that initially he had more shaky eye movements and he was not fixing that well, which has improved with time. So the vision improved with time. And cognitively also, he was like bright and interacting and interested in his surroundings, but more of gross motor delay. On examination, there was some features like retronathia, high-arched palate. He had mild facial weakness, and there was central hypotonia with good anti-gravity movements, but the DTRs were absent. So we did a nerve conduction study that was showing a motor sensory axonal neuropathy kind of pattern. So it was looking like a mixed UMN and LMN kind of weakness, and we sent the metabolic screen also, which came out to be normal. So initially, because there was some visual impairment which was improving, and on examination also he had a pendular nystagmus, so more of a congenital nystagmus with some hypotonia and areflex. So we were thinking of hypomyelination disorders, and we got the MRI done. So the MRI, so we'll be discussing now.
Yeah, right. Thank you. So we have the MR images on top of the axial sequences. Diffusion, there are some symmetrical changes in the bilateral globus pallidus, demonstrating restricted diffusion with corresponding low signals on the T1s and the slightly hyperintense changes on the T2-weighted sequences. Nothing on the SWI in the deep brain nuclei. The rest of the brain did not demonstrate any other findings. No dysplasia, no malformations. Corpus callosum is demonstrating a slightly drooping appearance. And if you observe the brainstem in the region of the clava is slightly prominent. So the thin sections, thin T1 sections, and you can appreciate this clava is slightly hypertrophied. Vermis also is demonstrating slightly reduced height. In view of the global pallidized changes, we did a spectroscopy and could not find any diagnostic peaks. So the scan was made. Child was sent for genetics, and it came out with a gene for INAD with uncertain significance. These are the typical changes of an INAD on neuroimaging. In a later stage, can present with cerebellar atrophy and hyperintense cerebellar cortex. They can also have SWI changes in the deep brain nuclei, and the clava hypertrophy is almost pathognomic, if I'm not mistaken, for the INAD related disorder. At this point, I'll open the case for further discussion.
Thank you, Nihaal. I mean, in this condition, 6 clava hypertrophy is always. The question is this clava hypertrophic or not? If it is clearly, then I think it's very likely. Maybe this MR was taken at a young age, because usually we see more cerebellar atrophy on presentation.
Yeah, it's at 10 months, right?
Yes.
The only question was these globus pallidus changes. I could not find them to be present with INAD. Yeah. I know they can be present with abnormal mineralization.
Later,
but not these,
yeah. Did you do genetic testing in the parent?
We have asked for parental testing, so the results are awaited.
So you wouldn't think it's not inconsistent with INAD, again, if I'm not mistaken?
The clinical picture fits hypomyelination or INAD. In the initial years, they will have almost same presentations. Yeah. Yes.
All right. We'll move on to our last case, should we?
Yeah. So this is a 9-year-old boy, and they came with the complaints of developmental delay and some behavioral issues. developmental delay was more of cognitive because he started speaking late at around 6 years of age in short sentences, but he was able to communicate well with the parents. But the intellectual delay was more significant. He initially had some motor delay also, but that was caught up. So currently he was not having any motor issues, but the cognitive delay was significant, and behavioral problems in the form of hyperactivity and stubbornness and some aggressive behavior was there. Otherwise, there were no other issues, no seizures. The vision and hearing was normal. But in the past history, there was this remote consanguinity, and this child was born full term but had some asphyxia during the delivery period, and he was admitted in the NICU for 3-4 days. The exact events during the neonatal period we don't know, but they said that the child was on tube feeds and required some support in the NICU, but did not have any seizures or any significant encephalopathy at that time also. So the neonatal period is not like fitting very much into the current illness. And also an examination, the child was having some dysmorphic features in the form of this prominent ear lobules and the pointed chin, slightly elongated face, broad root of nose. So we were thinking whether it's a genetic condition or an acquired condition. So we sent for the MRI scans, and the MRI scans, so we discussed.
So again, changes in the basal ganglia on both sides. You can appreciate that there is disproportionate atrophy of the caudate nuclei in comparison to the putamen, but putamen also demonstrates reduced volume. The global pallida also demonstrates reduced volume. There is secondary prominence of the frontal lobes because of the atrophy of the caudate nuclei. You have these hyperintense changes along the anterior and middle aspects of the putamen and the caudate nuclei. Nothing on the SWI to suggest calcification or hemorrhage. Going more superiorly, we have these perirolandic changes of gliosis on both sides. Corpus callosum is normal. Brainstem and cerebellum were normal. Spectroscopy did not suggest of any diagnostic abnormalities. So an overall appearance of striatal necrosis or striatal atrophy, more in the caudate in comparison to the putamen and the global pallidi, and symmetrical changes of mild gliosis in the perirolandic regions. If you concentrate on the basal ganglia, these are the various disorders which can present with basal ganglia atrophy or striatal necrosis. But the only concern was that does it fit? I mean, the question was, should be, if I'm not mistaken, this child had a static course of encephalopathy.
So yeah, initially he had some motor delay which got caught up, and cognitively he was still a little delayed, but like he was catching up. It was not progressive.
Okay. Given the bilateral perirolandic changes, I would think of an acquired injury, but in the acquired injury, if it's a hypoxic injury, the only question was the caudate nucleus is usually relatively less affected in comparison to the putamen, where the hypoxic injury is more common in the neonatal age group. That was the only doubt. The caudate atrophy can be seen in Huntington disease, but the clinical picture does not match with the juvenile Huntington disease. And the perirolandic changes are also not commonly seen. So at this moment, I'll open the case for further discussion.
I would add to your list HABC, which can lead to reduction of basal ganglia. Not that I think that this is the diagnosis in this boy. I see your arguments for some residual change, but the involvement of the caudate is really unusual and almost no thalamic involvement. So maybe the course over these 9 years or whatever is more in favor of a residual change than of a progressive metabolic or genetic condition. But the pattern is somehow unusual.
Yeah.
His facial features, could they be suggestive of fragile X? Yeah,
I'm not good in faces, but the MR would not be.
They would have more of a square jaw and a large jaw, and
yeah,
maybe I'm not sure.
It's long.
But the MR doesn't match. The MR doesn't match with the fragile X. They usually have posterior.
He had a motor delay initially, and now the behavioral issues have come up now.
Okay.
Any autoimmune cause to be because of behavioral issue to be evaluated?
No, the behavioral issues will probably be secondary to his cognitive delay, I would have thought.
Okay.
I don't think
It's not like acute. It's not acute. Like the cognitive delay is just there. It's more than motor. That's all.
Yeah.
I think clinically it points towards the hypoxic or acquired insult. The only imaging finding which was not typical was the caudate atrophy. Given the periglottic gliosis and absence of thalamic involvement also, as again suggested, slightly atypical for a like only hypoxic insult injury. What I would think on the imaging.
This is probably beside the point, but there is an app called Face to Gene. So you put the face picture, it will tell you which genes fit into it.
Okay.
It's called Face to Gene. You got the picture, no? You just put it in there, it will tell you which all genes fits into it.
Okay.
It's still learning, but AI, artificial intelligence.
Today, what is the follow-up you're doing for the child?
They've come here for the first time, so like now
Okay.
only they came through here.
Any further investigations to be done or planned?
No, sir. No. After the MRI, nothing has been done.
Okay. There are no further comments. I think that was our last case.
So we'll
Okay.
still keep it as that hypoxic injury only and
Yeah.
will not consider any
Yeah.
genetic or.
Yeah.
Thank you.
All
Thank
right.
you, everyone.
Right. Thank you.